spill. Damn it. Alright.
There's copies
Which
and stuff
one
up
is
there.
it? Right here?
On my desk.
Video's not available.
Well, just give it.
Does it take like time to wait for a while? Fresh it or not?
So then what happens is
Hey, Teresa. Teresa.
Air loading, temperature, reach trial. Oh, there we go. Yeah, try on your phone. Maybe your phone's better. You gotta go and record, right? Is everything on? It says this is on. We are good. It's streaming. It says it's streaming.
If you guys think of anything more on presenting, just throw something at me.
Are you doing?
I'm doing history of the mental health system. So I used to have John Pollock with me, but yeah, exactly. I grew up in the old ISAC funding bill for good measure. Just to remind you how awful it used to be.
HDMI cord's plugged in, and it's network.
Okay, we're good.
And the HDMI cord's plugged in firm. Yeah, so.
elevated chair.
We have rain and driving in the car.
Cedar River that way. Another piece.
We can have a picture of that.
Test, test, Representative Warren. Super, all right. Just want to make sure before we start that you can hear us well.
How did you get it?
For those of you who are wondering what we're doing, we're waiting for a couple of other colleagues. So waiting patiently, and we'll get started as soon as we get the committee fully gathered.
They said they had it now.
Hey, Lisa. You are. You are. Yeah, I'm at a meeting in Des Moines. Switching it. Yeah.
No, we're waiting for you.
It's all you, Mark.
Good morning, ladies and gentlemen. Welcome to our first meeting of the Mental Health and Disability Services Funding Study Committee. Say that 10 times fast. We're glad you're all here with us. I'm State Representative Joel Fry, and I just want to welcome everybody to the meeting. And the first order of business we need to do, I've called the meeting to order already, is to elect permanent co-chairs. And so I would open the floor up for nominations for permanent co-chairs. Representative Carlson.
Thank you, Mr. Chair. I'd like to nominate Representative Joe Front from the co-chair.
Senator Costello.
I'd like to nominate Senator Jeff Etzer.
Any further nominations? Seeing none, we'll close nominations. Those in favor signify by saying aye.
Aye.
Those opposed? Aye. Thank you. And I should say we have Representative Lundgren on the phone with us, just so those of you who aren't aware. She is with us.
Vote against you there?
She was in on the front end. So anyway, thank you for the opportunity for us to co-chair this meeting with you all, this meeting and the next. To start the order of business, I would like to, first of all, draw your attention to your packets, and in there you will see the rules that we typically have for our committees. Would like you to review those briefly. If you have questions, feel free to ask. If not, I would need a motion to adopt the current rules as distributed.
So moved, Mr. Chair.
All right. Any opposition? Seeing none, the rules have been adopted as distributed. Thank you. The second item of business that isn't on your agenda is I've asked LSA to read through our committee charge from the legislation that we passed last year so that we're all clear and ready to go with what our charge is for the next couple of meetings. So, Jess, take it away.
All right, so as stated in the legislation, the charge is to analyze the viability of mental health and disability services funding, including the methodology used to calculate and determine the base expenditure amount, the county budgeted amount, the regional per capita expenditure amount, the statewide per capita expenditure target amount, and the cash flow reduction amount. The committee shall submit its recommendations to the General Assembly by January 15th, 2019. So, in paraphrasing, you're looking at the way the levy is set up now with the current per capita regional expenditure targets and the fund balance reduction formula that's in there. And we'll talk about some of those things when we get to that part of the presentation. So.
Excellent. Thank you, Jess. I would like to go around the room and just have you all introduce yourself by name and district, if you would, so that those in the room who are observing the meeting and those online have the opportunity to know who's around the table. Senator, we'll start with Senator Reagan.
You want my too? Senator Reagan and I represent District 27 in North Iowa.
Senator Joe Bolton from Iowa City.
Representative Brown Powers from Waterloo. Representative Lisa Hedden from Ames.
Senator Jeff Edler, District 36, Marshall Tamer Blackhawk.
Representative Carlson from District 91, Muscatine.
Senator Mark Costello from District 12 in the southwest corner of the state.
And Senator Mark Segawart, Western Iowa, 6th District, Audubon, Carroll, Sac, Buena Vista, and eastern half of Crawford.
And on the phone we have Representative Lundgren. Are you there?
Yes, I'm sorry. Representative Lundgren, Iowa House District 57, Rural Disease County.
Super. Thank you. And again, I'm State Representative Joel Fry, and we're glad to have all of you here today. Senator Bolton.
Thank you, Mr. Chairman. Mr. Chairman, question about the charge. The charge is pretty clear. When I look at the charge and compare it to today's agenda, there's really no agenda items explicitly discussing the charge of the committee. So I'm wondering about that. And I don't know, how many committee meetings were approved for this committee?
Yeah, so we've had 2 allotted, and the agenda for today was set up in a fashion to be able to bring everybody up to speed as to where we have been at, because we do have members around the table who have not been in on these discussions. Okay. You and I certainly have been on many of these over the years. And I felt it was incredibly important, we felt it was incredibly important to bring everybody up to speed as to where we're at today and how we got to where we're at, so that we have that baseline and platform to be able to then launch the discussion around the financial.
Okay. The other thing I'd say about the agenda today, I note there's no opportunity for anybody that's come to this meeting during public discussion to address the committee, and would encourage, if there's time today, to allow for that. And then next time's meeting to schedule some time to hear from people that want to give us some advice. Thank you, Mr. Chairman.
So noted, Senator. Thank you. And as we put the agenda for the next meeting together, the Senator and I will certainly have conversation around public comment. The decision today was, because it's a historical review, and we're asking LSA to come and present that historical review, that there probably wasn't a lot of public comment at this moment on this topic, knowing that we will have plenty of public comment, I'm sure, at the next meeting on the topic. So thank you, Senator. All right, with that, I'd like to just offer a few opening comments. Yes, Representative Higgins.
Sorry, Mr. Chair, I just have a question as well on the agenda, if you don't mind. Could you just explain to me, I kind of had the same questions as Senator Bolton in regards to the agenda and talking about the financial expenditures, and I understand getting everybody up to speed. But can you explain to me a little bit on the tour, the 1245 tour, the reasoning for that?
Absolutely. We felt it was important to get committee members out to see some of what was going on as related to mental health and disability across the state. Again, recognizing that not everybody has sat around those discussions and has the full knowledge as what maybe you and I have over the years of sitting in these discussions. and also recognizing that the tour is going to give us a look at some of what core services look like within the Polk County area, and the opportunity to get members out and to understand in greater detail what's going on in our communities.
I appreciate that. I'm just hoping the members are also looking at what's in their own regions. Some have very large regions, some are smaller regions, and really look at that, and that then we can get information from our regional folks. Hopefully we'll present at our next meeting here as to the financial portion of it.
Certainly, yes, so noted, and we will be looking at that agenda and getting some of those individuals on the agenda as well. Yes, I would also reiterate that I encourage you all to go out and see what I'm sure you are, checking out what's going on in your own regions and in your own communities. We did actually look at getting outside of Polk County for that tour and actually holding the meeting off-site, but that was not something that we were able to accomplish due to accommodations with space at that location. So with that, this is what we were able to put together to get the committee members out to see some actual delivery of services across the state. And I felt it was very important for that to take place so that we know what we're talking about as we sit in these meetings. So again, back to opening comments, I would like to again thank all of you for coming and recognize the fact that we are sitting around the table today discussing some of the, I believe, most monumental legislation that the House and the Senate have passed in a unanimously bipartisan effort as it relates to mental health and disabilities in the state of Iowa. I believe that the legislation that we were able to pass was successful because of the complex needs work group that came together and were able to come to us with some very viable recommendations that didn't have an astronomical price tag that put it out of reach for the legislature to be able to consider within the constraints of the entire state budget. So I want to recognize that work group and their effort that they did in order to bring us recommendations that allowed us to be able to sit here today and have this meeting. I also would suggest to you that one of the most important pieces of this legislation that was passed last session was the fact that it actually, in my mind, brings mental health conversations and mental illness to the same playing field as all other disease in the medical field. That it elevates it no different than any other condition that one might be seeking out doctor's assistance or therapy or other services for. And I think that that is an important understanding for Iowans, that the legislature, the governor's office, found it important enough to proceed in the direction that we did this last year and to put it on the level playing field with all other health. The House, when we got the bill, also added a number of pieces to the legislation. We have conversation or legislation there around video conference hearings. We have opportunities for law enforcement to be heard in their issues as it relates to the transportation issues that they were facing with transporting individuals. We also have opportunities for communication between mental health professionals and law enforcement officials to be able to understand and identify imminent risks within their community. And then we have conversation there around civil commitment, pre-screenings, and the subacute bed tracking piece as well. So there were a number of pieces in this legislation that the House also sought importance to add, and the Senate also agreed and carried that legislation forward along with us. I'm excited because in my own region, to Representative Hedden's point, in my own region, I've had the opportunity to see some of the exciting work that they're doing related to the access centers, the subacute beds, and their intentions of what they hope to see develop in my own particular region. And so I encourage you all to go out and see what your regions are doing to better understand what is going on and the excitement that I believe that is across the mental health community in the work that they're able to now do because of the legislation that so many were involved in. Many of you around the table were a piece of that or worked on that, so I want to thank you for that as well. And with that, I'm excited to get this meeting rolling and to better have understanding about how we keep the conversation moving and the funding discussion alive. Mike, would you like to offer any opening remarks?
I'd just like to echo thank you to everyone who came out today to the meeting. I think this is a very important issue and looking forward to working with everyone here to move forward. Thank you.
Seeing no further opening remarks, we will go ahead and move on to the 9:15 portion of the agenda. Those of you who have been in meetings with me before, I will keep the agenda very tight and we will run on time as the agenda is printed. And so with that, we have asked Jeff Spenson, the Senior Fiscal Legislative and Analyst with LSA, to come and present to us today regarding a historical perspective around where we have been as it relates to mental health and how we got to where we were at last year and today. So with that, Jess, the floor is yours, and you have until 10:45, sir.
All right. Thank you very much. And I don't know how you want to handle this, if you want to interrupt with questions or if you want to...
Thank you for the question. I would choose to have you present, and then we'll take questions after that.
Okay. Sounds good. So this is probably about the third time I've given this presentation to an interim committee like this, or some variation of it, and there's probably been a half dozen or more interim committees on this topic over the years. I know a few of you probably sat in on a few of them. Previous iterations, I've had John Pollock up here with me, but he's traveling overseas. I know he was invited today, but he's traveling overseas. One would presume to get as far away from this conversation as possible.
Yeah.
So, anyways, so on the first slide, it starts with Senate File 69. There's a long history of mental health funding, and with the county homes and MHIs and everything before Senate File 69. But really, for our funding story, Senate File 69 is the beginning of why we are where we're at today. It's kind of everything we've done since Senate File 69 has been fit into Senate File 69, basically, or the parameters set up in Senate File 69. So what did Senate File 69 do? It capped the Mental Health and Disability Services levy at $214.2 million statewide. And it did that by locking in county levies at a dollar cap at either their 1994 actual expenditures or their 1996 net expenditures. The state then provided $88.4 million in property tax reduction to reduce that levy to $125.8 million. And I just wanted to note that this is the only levy that's capped on a dollar amount. Most other levies statewide, it's $1 per thousand. So this would be like $1.25 per $1,000 of property valuation on your house or whatever your property. And this one is there's a hard dollar cap for each county, and then they back into that valuation every year. So as population booms or as property values increase, this levy actually goes down compared to all other levies that actually go up a little bit. Let's see. And kind of to give you a little background on the thoughts of why they did what they did back in the time, and at least this is as it's been told to me, and I was in high school back then, so. I think legislators were worried about the property taxes increasing for the county levies, and there were some of them that actually were interested in buying out the system in general, so they started the $88.4 million. For some of them, it was a start of buying out the system, and in theory, they would have continued buying out the rest of the system after that. In addition, the way the things were set up is the counties had their like a hard dollar cap that they knew they were funding, and then the rest of the growth in the system was going to be the responsibility of the state going forward. So on to the next page, you can see I printed out a chart on page 2 or page 3 of where the levies were back in 1997, and this just shows you the great variation of where counties decided to lock in their levy rates. It kind of looks like chicken pox. They're all over the place. It ranges from the two dots up top. The first one around number 1 is I think Jasper County, and Wapello County is the other one that's really high. They're up around $3.50 or $3.70, and then the lowest county is Plymouth, down there on number 71, and they're, I think, let's see what are my notes. I think they're around 40 cents or 45 cents per thousand. The other counties down there would be like Dickinson, some of the other counties with some higher property valuation. As I said, counties had the decision on where they wanted to lock in their levies, so they had a little bit of leeway when doing this. Some of them, moved their levies so that because they were betting on the state to pick up all the growth in the futures. Others might not have trusted the state as much and kind of made their levy as higher or as high as possible to keep as much or as many dollars in their county levy. And then the other thing to remember when you start talking about property tax valuations, you have to think about there's property rich and property poor counties. So fairness, when you talk about that, I mean, there's Dickinson County, which has Lake Okoboji, so it doesn't take them a whole lot of dollars per thousand to levy, $1 million versus, some of the small rural southern counties, Ringgold or Decatur, that just don't have a lot of property, and so, it takes a lot more levy to levy those same dollar amounts. So that's kind of the way the historical levy was set up. So these were all locked in. Nothing was changing over time, and so then the state was responsible for all the growth on top of that. And so on the next slide, it shows you the state appropriations. You can see the dark blue line on the bottom is the property tax relief. That was the $88.4 million that was what brought down the levy from the 214 to 125.8, and that was phased in over a couple years. And then there was just the other main pots of money: allowed growth, community services, and there was some money from the social services block grant and a few other pots over the years. You can see that the funding generally trended upwards, but there was a recession around the early 2000s, and there's one around 2009 and 2010. So there was always a dip because money was tight during the recessions. Although I would also say that during the recessions as well, there was generally some extra Medicaid money that came from the feds, and so we got like an FMAP bump, and the counties were getting FMAP back then, so that was helping to fill some of those gaps. But there was different funding formulas. Actually, on the next page, it starts the funding formulas. So this is a sheet that ISAC used to hand out, and I put it in here not to make you read it all and study it, because you don't need to know this, because it's kind of ridiculous. But it just shows you how complex the funding formula used to be. There was the pot, like the community services pot, which all counties were eligible for, and then there was allowed growth, which had multiple pots within that, which was distributed based on per capita population. It was also levy amounts, fund balances, and there's a poverty level thing in there, and one of the things. So as you can see, there was all these different steps and variations that you had to go through to determine what the levy would be each year. There's also things within this called a ledge, and so counties would come up and they would have just a little too much money in their fund balance, or and they would fall off getting state appropriations, and so there was counties that would come in every year, it seemed like, just for a tweak because they were on the wrong side of the formula and they were losing money. There's probably only a handful of people in the state that actually understood how this formula really worked, and and not many of them were in the legislature because who knows? So yeah, how this works. So, but anyways, let's see. Another issue that popped up from time to time was property taxes are due in September and March, and so counties, they don't get money until September or March then from the levy, but if they're not getting state funds and they don't have much of a fund balance, they're having issues with cash flowing, and so we made fixes in the past to accommodate those things as well. But yeah, it was kind of an ongoing thing from between fiscal year 95, 90, or 96 when we started this, and 2012 or 13 when we bought out the Medicaid, and that kind of took a lot of the burden off the counties. On page 7 then, prior to FY 2013, counties were responsible for the non-federal share of Medicaid. That meant that they used to pay for the adult intellectual disabilities waiver, the ICFIDs, state resource centers, habilitation, targeted case management. A lot of these things are things we don't think of as being counties' responsibility anymore because they're all part of the Medicaid system, and counties are more just dealing with mental health. I mean, they deal with some of these, but not in the funding aspects. Between 1996 and 2013, the legislature, being a funding partner with the counties, was encouraging counties to, Medicaid or more of these services. Counties, were doing this as well, but some counties were a little reluctant because I think they felt they lost some control when they did Medicaid these services. The other thing that went on is counties maintain their own intellectual disabilities waiver under Medicaid. So you had 99 different waivers, and then you had the state waiver. There might have been another waiver for state cases. I can't remember if there was. But anyways, there was 101 waivers or different waiting lists. So depending on where you live statewide, you might have had a better opportunity to get on the ID waiver or get on the ID waiver or not. So yeah, it was also a very complex, or it was kind of a funny funding system as well. On page 8, the state was paying the counties or distributing money through the allowed growth formula and community services to counties, and then the counties were also using the property tax levy dollars. So basically, we were giving the counties money as the state, and then the counties were actually paying the state back for Medicaid. So there was this whole complex funding thing where, I call it kind of funding gymnastics, where the money was moving around and from pot to pot. So as we were kind of getting up or to fiscal year 13, the adult ID waiver and the ID system in general was putting a lot of pressure on the on the counties, and I think it was kind of squeezing out mental health funding to some degree, and so the state ended up buying out the system. I'll talk a little bit about that a little bit more here in a minute, but on to slide 9. So Senate File 2315, there's a couple bills before this that kind of set this up, but Senate File 2315 was kind of it really set up the way the system is now. It was kind of the seminal moment for that. So beginning in FY 2013, the state assumed the non-federal share of Medicaid that was previously funded by the counties. The act also directed counties to join into regions, and there's a regional map, and I'll talk about some of these other things on the upcoming slides, so I'll get to those in just a second. The act created core service and core plus service domains, and I didn't put those in the presentation for today, but I listed the code chapters 331, 397, and they're all listed pretty clearly on what's now required. The act also set just a minimum federal poverty guideline, 150%, and they allowed some cost-sharing options above that as well. And then the act created this new per capita levy structure, so you hear 4728, that was that part of this act. So if you want to kind of see where the beginning of where the system is at today, that act made a lot of those big changes. On to page 10, so the first thing that act did, or it bought out the Medicaid system. So these just kind of gives you an idea, dollars and cents wise. These are the actual dollar amounts that in fiscal year 13 that the state paid for, which were previously funded by the counties. So you'll see that the biggest chunks were the ID waiver and the ICFIDs and state resource centers. The state took $240 million off the counties, but they also took almost all the counties' money that the state was appropriating to them. So you'll see they no longer appropriated a lot of growth, property tax relief, community services, and all those other little pots of money. In addition, the state put up an additional $50 million in general fund money to fund this as well. So it was a big burden to take off the counties, especially because Medicaid was continuing to increase in costs. Slide 10, or the next slide, is just an MHDS regional map. This is the current map as of July 1st, 2018. It's changed a little bit since it was originally, the original inception of this back in 2015. And it's probably not done changing. I know there's a few counties up in the County Social Services region, Kossuth, Winnebago, Hancock, that are looking at joining a different region, and then I think there's the Sioux Rivers region is also, Sioux and Plymouth are looking to go to a different way than Woodbury. So there's a little bit of adjustments that was allowed I think in last year's either appropriations bill or one of last year's, or maybe it was the complex services needs bill that allowed for those counties to look for different regions. But anyways, in general, these are the regions right as they stand right now, and yeah. So the biggest thing that, or one of the biggest things that Senate File 2315 did was set a new per capita levy structure. The levy structure still worked inside that old Senate File 69 dollar amount, and actually, if you skip to page 13, I like the picture better to explain it. It'll be a little easier to explain it to you. So if you look, there's the red line in the middle of the page that's 4728. And so what Senate File 2315 did was it required counties above that line to reduce their levy to that line. So there's probably, it was 40 some, or where's my notes? 40 or 50, it was maybe 50 counties or so that had to reduce their levy to 4728. And then there was 40 some counties that were supposed to get an equalization payment. So the thought was that these counties are going to go join regions, and so to make regions work, everybody needed to start with the same amount of money. So 4728 was that amount of money that everybody was going to start with. So there was an equalization payment that was made for a couple years that brought the counties below up to that line. In fiscal year 14, $29.8 million was provided, and then in fiscal year 15, $30.6 million was provided. That number ended up being reduced by about $10 million because of a Medicaid offset, which we'll talk about here in a minute. But this really reset the system and had you looking at it on a per capita basis. The reason why that was chosen, we looked at all kinds of different formulas when we were doing this. We looked at a school aid formula. We looked at just doing different levy rate limits, and the prevalence of mental health seems to be fairly standard across counties. It doesn't matter if you're in an urban county or a rural county. The mental health rates are pretty standard, so they just decided per capita was the best way to fund the system at that time. So the next big thing that happened was Medicaid expansion. So Senate File 446 took advantage of the option of the Affordable Care Act to expand Medicaid. So that expanded coverage to childless adults and or childless couples and single adults up to 133% of the federal poverty level, another 5% income disregard on that. And this was a boon for the counties because they were able to provide services that were Medicaid funded that were previously paid for with 100% county dollars. So the other big thing it did is you could classify individuals as medically exempt, which is a Medicaid term that basically means that an individual has a disabling mental disorder, including adults with serious mental illness, other individuals with chronic substance abuse disorder, or individuals with serious complex medical needs or conditions, and it goes on. But the big thing with that is you can classify, or if you classify an individual medically exempt, they can be put on full Medicaid. And then they're eligible for a whole host of services that aren't on the regular health and wellness plan, because the regular health and wellness plan is was just the state employees' health insurance at the time. And so this allowed, full Medicaid allowed for things like behavioral health intervention services, intensive psychiatric rehab, assertive community treatment. So some of those services that you even passed last year, you're encouraging to make core services last year. So with Medicaid expansion, as part of Medicaid expansion, on the next slide, there is also this thing called the Medicaid offset. So there was some concern with all the fund balances that were building in the counties, and this was going to be a kind of a this was going to be a bit of a windfall for counties because the state was paying for the non-federal share of Medicaid, but the feds were paying for most of it, and so the legislature required 80% of the savings that were reported by the counties to be returned to the state to help pay for Medicaid services. So what happened is about 6 months into the program, the counties made an estimate of what they were going to save for the year, and then the state ended up taking 80% of that back, either through reduction of the equalization payment, that $30 million equalization payment, that was reduced by $10 million, or if there was no equalization payment to take back, the counties were required to reduce their levies. So the state took back $10 million, and then levy rates were reduced by another $6 million statewide. The offset was really only in effect for 1 year, so it was a 1-year thing, and then it was repealed because of other funding issues going on with the counties. And then the next big thing that happened a couple years ago, you guys passed Senate File 504. So Senate File 504 revised the Mental Health and Disability Services property tax levy by equalizing the levy on a regional basis. So in previous years, you were at kind of the ramp where the ramp were below 4728, and then everybody else was at 4728. This put everybody in the region at a level playing field. So if you look at the next page, it actually shows where the counties are now or today. They range from, so there's 14 different regions, and so there's basically 14 different levy caps now. They range from 2584 in kind of the 3 counties in the heart of Iowa region, that's Dallas County's region, to 4728 in the south central Iowa region and down there. So you've come a long ways from the scatter chart that on page 3, which is actually, I sorted that by region as well. So you can, if you just put one on top of each other, you can see that you've come from chickenpox to what looks like a DNA analysis or something like that on this page. So the other big thing that Senate File 504 did was it required it gave counties 3 years to spend down fund balances on services required in their mental health, regional mental health plans. Statewide fund balances totaled $148.7 million at the end of 2016 and $140.6 million at the end of 2017. The 2018 numbers aren't available yet. They aren't reported until December 1st, so as soon as we get those, we'll make those available to you. And I want to say, too, fund balances built up for a number of reasons over the years. There was really kind of four big things that built up fund balances. At the end of the last recession in 2009, 2010, there was the American Recovery and Reinvestment Act. This was back when counties were still funding Medicaid, so that kind of helped start building up some fund balances. There was also equalization payment. When that went out, it didn't consider fund balances, so counties got the money whether they needed it or not. So that was kind of the second big thing that helped start building up fund balances. The third was Medicaid expansion. So there was additional funds through Medicaid expansion, which built up fund balances. I think the fourth thing was just that counties didn't necessarily trust the state and what they were planning on doing. As you can see, there was a lot of changes through those years, and I don't think there was a lot of trust in the state coming through. So I think some counties probably sat on some money just so they made sure they could fund the services they needed to. So what Senate File 504 did was, beginning in FY 2022, counties are limited to a fund balance reserve, for cash reserve purposes, of 20% of gross expenditures, and then, or if the region's population is greater than 100,000, or 25% of gross expenditures if the region has a population of fewer than 100,000. And so this is really to cash flow that first quarter. So from July 1st to September, when the property taxes start rolling in. That was kind of the thought about the 20 or 25%. And then beginning 2022, counties, or 2023, counties will be required to reduce their levies by any dollar amount that exceeds those cash flow amounts. So if there's still cash flow out there or that are above the 20 or 25% limits, counties are required just to reduce their levy on a dollar for dollar basis. The other big thing that Senate File 504 did was provided a temporary fix for Polk County. Polk County is a region unto themselves, and they've had quite a bit of population growth since 1996. I think their population's increased by, let's see, I don't know, like 120,000. It's about 36% population increase. So they're operating under a levy that raises about $14.6 million, and their expenditures are closer to $21 million. So what Senate File 504 did was it transferred it required the board, or Polk County, it required the Broadlawns Medical Center Board to transfer $2.8 million to the Polk County Board of Supervisors to be deposited into the MHDS fund. In addition, Broadlawns was also required to donate $3.5 million worth of services. So that, between those two pots of money, it kind of helped get Polk County over the goal line to get them to the amount they needed to fund services in the county. So, that's going to be in effect for 3 years, fiscal year 18, fiscal year 19, which you're in now, and then next year in fiscal year 20. The next thing is what you passed last year. I just wanted to put this. This is from my fiscal note last year, and just to remind you the new services that were funded last year. Most of these services are Medicaid services, but the regions do have a big share in funding them. There's startup costs, and then there's ongoing costs because Medicaid only pays for beds when the bed is full. If there's going to be some idle time, and counties will be responsible for some of that idle time and some of those overhead expenditures. So you'll see the total amounts for fiscal year 19 and 20 that were estimated at the time. There's the general fund amounts was appropriated in Medicaid for fiscal year 19, and I know in the department's budget book this year they've requested that amount, or I don't know if it's exactly that amount. It might have been re-estimated a little bit, but a similar amount for fiscal year 20. And you'll see the share that the regions are anticipated to be putting in for the new access centers and things that are being started up around the state. So these are all services that were previously might not have been core services, but that became core services. So they're things that are now required to be funded by the counties. So I just wanted to bring that to your attention. It's about, the counties will be responsible for about $4 million this year and another $10 million next year. And the state responsibility is about $800,000 or just under $1 million this year, and closer to $6 million next year. So that kind of brings us to, actually I want to stop for a second and just draw your attention to this spreadsheet. I just put this in your packet more for informational purposes. You can kind of see where the actual and maximum levies have been over the last few years. As counties have been spending down fund balances, you can see the actual levies have decreased every year for the last few years. I put a percentage. You can just quickly see kind of how much percentage of the levy is being used. You can see in most regions they're levying a standard amount percentage-wise, and just kind of gives you a general idea of what's going on. So that kind of brings us to outstanding issues. So, I mean, what are you here to look at? I read the charge earlier, but regions are looking for a long-term, stable funding source, and I think that's probably the first thing they tell you. They just want to be able to, not, fund this in the region and not worry about it. So that's one of the reasons why you're here. I think, someone they'd also like equity between regions, as I showed you with the chart, the graphs. You've come a long ways in providing equity between regions, but there's still a little bit of difference. As regions start funding some of those new core services and those fund balances run out, there's they have nowhere else to go because there's no state money left that's being given to regions. They're stuck with whatever levy limit, you know, that they're working within. And some of those levy limits, I mean, they're all still based on that 1995 Senate File 69 cap statewide. And so you also have regions with high population growth. I just went and pulled, you know, Dallas, Johnson, Lynn, Polk, and Scott, you know, 5 of the bigger counties. Their population has grown 33% since 1996, so they've grown from about 830,000 to about 1.14 million. So it's a pretty substantial population growth, and they're still working within, you know, the same levy limits from 1996. You also have regions with low populations, you know, kind of some of those regions in the southern tier that I think the region that's at 4728 is, they're all actually levying 4728 because, you know, they don't have the economies of scale, they don't have the providers, and so, you know, things cost more, and it's hard to find people to provide services down there. And the other, you know, big issue you still have to address is you know, Polk County. They're always the, you know, the big elephant in the room. They're approximately, as I said earlier, about $7 million short of their expenditures compared to where their levy's at. So that's, you know, an issue. Some of the things that have been talked about over the years, these aren't my recommendations. These are just things that have been brought up. You know, you can allow regions to levy a standard amount per capita, some standard dollar amount, whether that's 4728 or some different amount that can be calculated. That's an option. You know, it's a pretty easy calculation. You just take the population. If you want to know how much money it would raise, you just take the population, which is 3.145 million, and you multiply it by 4728, and it equals 148 million. So that's just a general idea of you know, what that would be, or you can adjust that number up and down depending on where you want to go. Another option, you know, that's been talked about over the years is the state, you know, completely buying out the mental health system, and you know, if you came up with $120 million, you could own yourself a mental health system, you know, that's something that's been talked about in the past. It's just one of the many options. Another option would be to just fund the growth again using general fund appropriations. That was done in the past, and you can set that up as if there's, you know, if you want to fund the growth going forward again with just general fund populations, that would cost the state a lot less in resources. And something else that's been talked about more recently, is just raise sales taxes and dedicate a portion of that to mental health. I had Kent Holmes, who does sales tax stuff for us, calculate what 1/8 of a penny would be, and it's about $66.1 million for each eighth. So for 2/8, you could buy out the mental health system. If you wanted more, you could fund the children's system that there's a children's board is talking about. So that's an option out there. So as you can see, we've come a long ways from where we started back in 1996. There's been many iterations, but every iteration, as far as the levy is concerned, we've kind of still worked within that or Senate File 69 funding cap to some extent. Yeah, that's kind of where we're at, and I'd be happy to take questions.
Thank you, Jess, for that historic overview of where we have been. What I'd like to do is open it up for questions. I wanted to make sure that we have plenty of time during this segment for all of us to get our questions out on the table so that LSA could hear what we were beginning to need and look for and what they would be needing to put together for us. Those of you in the lobby who may end up as a panel speaker or as a speaker in our next meeting, you all will have the opportunity to hear what we're starting to dig through and understand and want more of. So with that, I would open the floor up to questions. I do have a few questions to start with, Jess. When I look at page 20, that's your spreadsheet of the House File 2456. So the little over 876,000 is what we budgeted this last year, and then the 2020, not quite 6 million is what we think to fund. Now I think I heard you say that the governor has said that is in the budget proposal for the fiscal year.
Yes, DHS just recently submitted their budget book, and it's their recommendation to the governor on what to fund, and I think it's around 5.2 or 5.3 million. I don't know, Teresa, like approximately. Yeah, it's around there. So
I think it's important for the committee to understand that chunk of money right now is built into a budget somewhere. So that's not an over and above extra chunk of money that we're talking about, correct?
yeah.
My second question for you, I just want to make sure I heard the date right. Did you say December 1st is when you expect to have fund balance reports in and available for us?
Yes, I checked with Jamie Cashman the other day from ISAC, and he said they're due to them December 1st, so
Okay.
somewhere around there we should get an idea.
Because I think that'll be key information for this committee to have available to us for when we come together again. My next question is related to the Senate File 504 and that 25 or 20%, 25% or 20% fund balance. 3 years, but my understanding is we have some regions who are already zeroing that fund balance out today. Do you have any understanding why that's going on as fast as it is, or the rationale behind that?
I hate to speak for counties or regions on what they're doing, but as you can see in the spreadsheet that I handed out, there are some regions that are levying zero. They may think that they have enough money. The fund balances were large, and so they may think that they have enough money to fund their regional services and any new Core Plus services or core services within that fund balance, or they might be worried that if they don't spend it down now, they'll have to spend it down later. So I don't know why.
So I think, again, for those of you in the lobby, that's critical information for the committee to have greater, deeper understanding on as we get into our next meeting. Do you know what the full percentage is across all regions of levying is at this point? And so 100%, we could obviously levy 100%, whatever 100% equals in dollars, but do we know how much is actually getting levied?
Yeah,
Is that on your other
at the bottom of my
spreadsheet?
spreadsheet, I think it's like we're levying like 63%.
There it is, the very bottom right corner.
Yep.
Second page.
Yep. Third page, yeah.
So as I read that here, that we're levying 63% of what actually could be levied across the state for mental health.
Yep.
Let's see, I think those are my main questions at the moment. I may have a couple more to come back to, but don't want to hog all the time here. So I'll turn it over to Senator Edler if you have any questions.
I'm okay at this time, and I would extend the offer on Senators and Representatives.
Representative Carlson.
Yeah, you mentioned a couple times if we wanted to own a mental health system, it'd be 120 million, right? So that is the total, 120 million is what you are suggesting is the total cost of the mental health system.
Yes, so I don't have actual expenditures for fiscal year 18 yet. I'm looking at actual expenditures for 16 and 17, and then budgeted expenditures for 18 is 103, 107, and then 128 was budgeted for 18. So I'm guessing it's probably in that. It's usually budgeted usually comes in, or actually usually comes in a little lower than budgeted. So it's in that ballpark of 120 million-ish, maybe give or take a few million.
Irregardless of the source of the revenue, the 120 is the total number.
That the counties are funding right now.
The counties are funding.
Yeah. I mean, the state's funding it's like a significant portion through Medicaid services. I mean, I think I had DHS pull that for me, and it was like $600 million or $590, $600 million in total funding, state and federal, that's being spent on Medicaid services.
But the 120 is county.
Yep.
Any further questions, Representative Carlson?
No.
Senator Bolton?
Yeah, thank you, Mr. Chair. Jess, thanks for the presentation. So, the regions, counties/regions are sensitive to things the legislature does, and sometimes we pass laws that make them do things, and in this case, send down their ending balances, basically the reserves. The reserves are largely a product, I think, of risk aversion. Counties over time, now regions have levied and they look over their shoulder at what the state's up to, and sometimes they pile up a little bit of extra money because they're not certain exactly what hoop we're going to make them jump through or what new service we're going to make them provide. Actually, with the complex needs legislation, we not only, we said we want you to do more things, and we want you to spend some of your money to do them. Okay? And that's going to play out here in the next couple of years about how that goes. And as I look at the levies, and we're levying 63% of what approximately $115 million worth available, the levy collection is about $72 million is in 19, if you look at it. But it's kind of concerning that we have 14 counties levying zero, right? They must have ending balances in place. Now, if I'm a taxpayer in one of those counties, I guess I got a tax reduction. I might not notice it. But, you know, one of the things about property tax is, both for the providers and the people that need these services, it's been this extraordinary stable amount of funding. It's been this extraordinary stable source of funding. It's really regular. Property taxes, while we've limited the dollar amount available, it's been there for the service providers in the counties over time. So I think that one of the challenges that we have is making sure that we send signals to the regions that, as Jess pointed out, I think, and I think it's the point that he's echoing from the regions, is they want stability. They want to know what the rules are about what's expected of them and so on, especially where the money is concerned, because I think none of us think that we should stockpile county property tax money in this fund. We want it to be levied and spent for services that people need. And I think that it's not a new issue. It's been an issue that's been around for a while. Anytime we do things, it seems like those ending balances grow, and then we say, you better spend the money. So I guess in 19, these levy rates are kind of a reaction to what we've been up to. I think the concern I have is as we look ahead to actually implementing the complex needs bill, one of the questions I have about the money that's appropriated in 2020, nearly $6 million, I think it is, how is that to be appropriated to the regions?
So that money is actually just appropriated for Medicaid, and so it's funding the Medicaid portion of those services. So it's not distributed to the regions. But it's paying for services that are being created by the regions, or it's assuming those services are being created by the regions in access centers and assisted community treatment and Irish homes.
So it's the state match for that service. Okay.
Yep.
That's all the questions I have at the moment. Thank you.
Further questions? You bet, Representative Higgins.
Thank you, Mr. Chair. Just a couple questions kind of going off what Senator Bolton was talking about. So I know with the complex needs work group, does this take into consideration the programs that the regions are to implement? You know, there's always startup costs and then to maintain. So is that incorporated in that dollar amount that you're proposing there? Or?
Yeah, I mean, it's an estimate, but that's what the $4 million and the $10 million regional shares is kind of those startup costs and some ongoing costs as well to fund those services.
Okay. I guess the other, more of a comment that I have for this committee is I know that there's been part of the complex needs work group and some of the proposals there for Medicaid to pay for a number of those services, or counties are to bill for Medicaid services. Unless our managed care companies are paying the correct amount and on time to providers, that becomes a cash flow problem for those providers. And I know of a couple agencies in my region that my regions had to step in and provide some additional dollars because they aren't getting the money coming in. So that's going to be another reason why counties may have some additional cash flow dollars. So that is just something to take into consideration. And then I've also heard some conversation on regards to whether Medicaid can be supplemented by counties or not pay for some of those beyond the base rates. And if that is the case, if counties are to step in and pay for those beyond those base rates, I have a concern as to how they're going to meet the needs of all the programs listed out in the complex needs worker. So I think that's something we need to be very cognizant about and be watchful on it, and I'm hoping that will be part of our discussion at our next meeting, Mr. Chair.
And I think there was a discussion at the last MHDS commission meeting on your last point. I think they said that counties can pay for if they want to, but they weren't encouraging that, obviously. So that was kind of the general discussion, but it happened at the last MHDS commission meeting.
So just a quick comment then. So if we're giving the MCOs the money to provide those extra services, do we have an accountability sheet to know that those services are being paid for from the MCOs? Because as I've talked to, some of the providers in my area, they're not getting the rate, or the rate is varied. And so how are we tracking that, I guess, is my concern or question.
I haven't seen what the performance measures are, and I would probably defer to somebody from DHS to actually tell you what was being done but I can tell you there is accountability. I don't know exactly what all those accountability measures are to guarantee those things are being provided, but yes, I know the department is encouraging the MCOs to work with the regions to get things set up as well. So.
Senator Costello?
Okay, so we've got the $6 million that we're going to be responsible for, and are we asking the regions are carrying a lot of this? Are we drawing down their money so that there's going to be a point where, we've got to spend a lot more money, or how close to sustainable is what we're doing now with the regions, what the amount they're contributing? Can we sustain that amount?
That's a difficult question because there's 14 different regions, so I would say there's 14 different answers on how close we are to being sustainable. I would think in some regions you can sustain where you're at for a while, where others, the small rural region in southern Iowa that's already levying 4728, they're probably going to be in trouble for that. Polk County, some other regions that have had a lot of population growth that'll be in trouble for that. So there's not a single answer. Or, this is when you really need to act and do something. But they'll kind of be dominoes over time as regions get in trouble and need additional funding. I think would be the best answer, depending on where they're at with fund balances and their levy rates, because those play into everything. So.
Okay, thank you, Mr. Chair.
Senator Edwards.
One of the things that I would like to see is isolation of the expenditures between what we would call the old core, the core plus, which we essentially have with the sheet you provided. And the other piece of the puzzle is isolating how much of today's budget has been used for children's mental health services. Because we're in the process of working on the state board with children's mental health services. And I think it's very important to know what that number is, that even though the regions are not charged to provide those services, we all know they have been, and really trying to get a good number put on that for us. So.
I think somebody was tasked with the last children's board to hopefully come up with that number. So we'll see if we can break out the old core or the new core plus services that are now core services. So.
Senator Bolton.
Thank you, Mr. Chair. Just following up on Senator Costello's question, which I think was a good one in terms of where do we need to be with funding to be sustainable? Not only taxpayers know, but providers know and the regions know, where we can get to some stable place. I think it would be helpful for our next meeting to have a panel of regional administrators to kind of give us a sense of because I do think it does vary by region where people are at. It might be helpful for the committee to hear directly from people managing the money about their various places that they find themselves. The other thing I think is coming, we've told the regions we want them to do access centers and sort of community treatment and more subacute beds, more intensive beds, and in the next couple of, I mean, we're in rulemaking now, none of that's begun, but I suspect in the next couple of years, the expenses for the regions are going to grow as they provide more of these services, some of which are kind of expensive, right? So we remain in kind of a changing environment for this regional system, and so I suppose we need to be flexible as we learn more about the needs. And I think one of the big remaining questions is, in terms of developing these services in the regions, are what willing providers are going to step forward to expand services in this managed care environment where they're nervous now about getting paid on time by these MCOs. So I think we're moving into a period of some uncertainty about these costs that regions are going to face, I think. Thank you.
So Jess, if I could take us back to slide 22. I'm going to pick your brain just a little bit and let you hypothesize. How's that sound?
Yeah. Looking forward to it.
Yeah. I'm looking at the first bullet point where you're talking about a standard per capita dollar amount. And I know these aren't LSA's recommendations there. You've gathered this slide from things you've heard across all papers. But when I think about what that might look like, or a number, or is there any, have you heard or have you all hypothesized any numbers that you could throw out for us to even have a ballpark idea, aside from 4728?
Yeah. So 4728 was created, I came up with it because I was running a bunch of different scenarios back at the time, and that was generally where non-Medicaid expenditures were falling back then. So around that was kind of where we thought they were going to be going in the future. As I said earlier, the system, the county expenditures are around $120, $130 million. You're asking counties to do more with these new core services, though, so that number will likely increase. So, it's somewhere in there. And the other thing you need to consider, though, is the regions might not. Some of those smaller regions that have less population might not be able to levy enough dollars even at 4728 to make things work. So there's some issues there with smaller population size regions. So there's a lot of different factors that go into it. I haven't done any analysis on what the right number is, but it's somewhere around there.
So as I hear you talk, one of the things I guess that's running through my mind at the moment, it's always a caution to say what you're thinking publicly. But as I heard you just reference that, I wonder if one of our factors we should be looking at is size of regions as well. Economies of scale. Do we have the ability to be able to provide what we need in smaller regions or more rural regions? So that may be a conversation to put on the table as well. Are there further questions from anyone around the table on the topic for Jess? If not, I want to take you to one more slide.
Okay.
Slide 5 and 6. You glossed over them, you did not describe it to us, and you indicated to us we might not be able to understand them. So I want to know if LSA can talk these slides through as well.
Oh, absolutely. No problem. No problem.
Just kidding.
Yeah.
Folks, I'm getting a lot of dirty looks from the members around the table. Don't make
I have the full-size sheet if anybody wants to read it. It's all
right, thanks.
It's a lot of fun. Yeah.
Jess, thank you for your time and for coming before the committee. I appreciate the information, and I'm certain you'll be back at the agenda. And we have Doug Wilson from Integrated Telehealth Partners who will be addressing the committee and sharing with us a perspective of, one, what they're doing within the context of mental health in the state of Iowa, and also just to get our minds churning around what we might be able to glean or utilize from an organization like this that is in the midst of mental health within the state of Iowa. So with that, Doug, we're glad to have you here with the committee. Feel free to proceed, and you have on the agenda you have until about 11:45, but you've got a few extra minutes here.
Perfect. Thank you. Well, first of all, thank you. Oh, do I need to hit that? Perfect. Thank you for the time and the opportunity today with the committee. My name is Doug Wilson. I'm the founder and president of Integrated Telehealth Partners. We provide telepsychiatry services across the state. We're located in West Des Moines. If you turn to the first slide here. So we're an organization that has now grown to 45 people dedicated to increasing timely access to psychiatric services via telepsychiatry. And currently, we've provided over 40,000 hours of telepsychiatry services here in the state. We have 31 psychiatric providers that work with us. It's a combination of child psychiatrists, adult psychiatrists, as well as psych-certified nurse practitioners. Our customers include, we've got contracts with 10 of the mental health regions, 20 mental health clinics, and I think we serve approximately 40 different satellite locations through those organizations. We work with 3 ACT teams, 51 hospitals across the state, 57 county jails, and we also work with 4 crisis centers as well. So if you go to the next slide, we're actually providing services in some capacity in 77 of the 99 counties in the state. So we feel that we've got a strong presence and good understanding of the system, especially in relation to law enforcement as well as hospitals and outpatient services for that matter as well. And so the discussion today really is going to be around our crisis services. And so what our crisis services are is we've got a team of psychiatrists that are available 24/7 around the clock, and they currently are working primarily with emergency rooms, also some crisis centers, as well as some substance abuse facilities as well. And actually that's on the next slide. And the way that that's set up today and being funded is primarily through 9 of the 14 mental health regions that have really stepped up and recognized the fact that this is a much needed service for those patients that are in crisis, really with the goal of trying to divert folks and getting them to the appropriate level of care, knowing that many times when a patient presents, especially in an emergency room physicians tend to be, very conservative and cautious. So there's a tendency that they may recommend hospitalization for patients that may not necessarily need that level of care. And the biggest reason for that tends to be their concern from a liability standpoint. Even if I'm not certain, I'm probably going to side on saying let's hospitalize because I don't want to run the risk of discharging somebody from the ER. There's a bad outcome, and now all of a sudden that creates a liability issue. And so that's really where there's been a significant benefit from our service, because we now can offer a psychiatrist, a trained professional in that capacity that can connect in via telemedicine, see that patient, do a full assessment, and then in collaboration with that ER physician determine the appropriate level of care. So this way we're really sending the appropriate patients to hospitals, and we're discharging appropriate patients to other services, whether that's a crisis center, a subacute facility, whether that's just an appointment with their outpatient provider as well. One of the concerns that the regions have brought to us since we've started the service is certainly some concern on sustainability from a funding standpoint. And so we've started to explore and look for some alternative funding sources. So that's kind of an ongoing process. We've been in conversations with the MCOs as well in that. So that's kind of a to be determined as far as what those options look like. And from the cost side of it, the challenge really comes down to the fact that, to make a team of psychiatrists available 24/7, you've got to pay for their time. And it's really hard to allocate and say, well, we're only going to pay you X amount per visit when you can't predict how many people are coming into the ER or coming into crisis on a given day. So that's really where the cost side of it boils down to. And then on the next page, this just really outlines our service. This little flow chart. So when the patient presents in crisis to, like I said, primarily it's in the emergency room. On occasion, it may be in a crisis center. the hospital notifies us within 2 hours. We connect in, again, have a psychiatrist or a psych-certified nurse practitioner connect in via telemedicine. They do a full assessment, determine the appropriate level of care, and in addition to that, they provide medication consultation to the ER physician. One of the challenges is there's patients that are in the ER physicians may not be entirely comfortable with certain psychotropic medications or treating certain conditions, so they provide consultation to get them started on treatment immediately. And then once that level of care has been determined, we have a full-time patient advocate team that finds inpatient beds on behalf of the emergency room. So they're working around the clock in our office, contacting every inpatient unit dozens of times each day to find placement, for these patients that do need that level of care and then of course once placement has been found, we do a warm handoff between the inpatient unit and the emergency room, and then they're transported for that. And so on the next page is just some of our data. So we've now managed over 4,500 cases in Iowa emergency rooms. And on the left side there on the pie chart, there's the results of the cases that we have managed. 53% have ended up going to an inpatient mental health facility. 40% have been discharged to outpatient follow-up services. 3% have been discharged and returned to a facility. I mean, one thing that is common is patients who may come from a group home or residential care facility, and typically what we found is medication consultation and adjusting their medications there in the emergency room and then discharging them back to that facility tends to be most successful because they are a challenging group to get placed into a hospital for that criteria. And then 3% have been discharged, and then 1% have left against medical advice. So that's a breakdown there. On the right-hand side, this is some data on the patients that we have placed. Our median placement time is 5.2 hours, and of the cases that we've placed, 13% have required to stay in the ER for more than 24 hours, and then the average round-trip distance, just one round trip, that's going and taking them to the hospital and coming back, and then obviously there's a second trip to pick them back up. But the average distance is 295 miles for that. And one distinction that I do want to make clear as I go through the presentation is, from our data, what we see is it really is kind of the 80-20 rule, that 80% of the patients that we're seeing have a very predictable path. So they clearly meet criteria for hospitalization. We know that virtually every inpatient unit in the state, they're going to meet criteria for, and they're going to be admitted to one of those hospitals. It really then becomes a matter of you've got to contact all of the inpatient units and find out which one it's going to be. Now the other 20%, their path is more complex and less predictable, and these are the patients that you typically hear about the most often. They're the ones that unfortunately do sit in the ER for a long time. We had a 12-year-old last week that sat in the Allen McKee County Hospital for 7 days. And so those are the ones that become complex and really take up a lot of the resources. So I do want to make that distinction that, for 80%, it is a predictable path, and for the other 20, that's where it gets to be a little more complex and difficult for that. And so then the next slide is just some data that breaks down that we accumulate on knowing exactly what time, what days of the week, when are these patients coming through the emergency room, and when are we being contacted. And so we're tracking all of this information, all of this data, really to help us identify trends for a couple of reasons. Number one, certainly from a staffing standpoint, but also just identifying what are the trends and how can we better manage and become more efficient in the system for that. And then I want to share an example, and I think this is probably, a common example that individuals such as yourselves hear an awful lot about, especially from law enforcement when it comes to travel and what's being asked of them. So, and this is two actual cases that we had on August 2nd, where we had a patient that was in Manchester, Iowa at Regional Medical Center, and we also had a very similar patient in the Clark County Hospital in Osceola. And I'll get through the whole game and process for getting somebody placed, but ultimately what happened was that patient in Manchester was accepted and admitted to Jenny Edmondson Hospital in Council Bluffs, requiring them to travel 572 miles round trip, which is 9 hours of travel time. And the patient in Clark County in Osceola was placed at Allen Hospital in Waterloo and traveled 316 miles or 5.5 hours. And this happens often. We just looked at 1 month of our data and quickly came up with 20 scenarios very similar to this. And so on the next slide, I think what everyone would agree the ideal would be is why didn't that patient in Manchester go to the hospital in Waterloo, right, which would have been 96 miles, and why didn't the patient in Osceola go to Council Bluffs, which would have been 258 miles. It would have been 535 less miles of travel and saved 8 hours of sheriff transport time. And in order to understand that, it really comes down to the process and how you have to, essentially what you have to do to find an inpatient bed. And so the way it's done today is you essentially are contacting every inpatient unit in the state. So in our processes, we contact the closest inpatient unit and work our way out. And how that process works is you call, you present a case, and then if an inpatient unit has a bed that they think may be appropriate for this patient, you then fax somewhere between 30 to sometimes up to 100 pages of documents to an inpatient unit for them to review. They then have to meet with the attending psychiatrist to see if they are willing to admit that patient. And this whole time period, that takes on average about 3 to 4 hours before you get a response back from an inpatient unit. So after I call the first one, what am I going to do? I'm not going to wait 3 or 4 hours to see if that one hospital takes my patient, right? I'm going to call the next one, the next one, the next one, the next one, the next one. I'll work through the whole list before I ever hear back from hospital number 1. And so then it's just a matter of whoever says yes first, that's the bed I take, right? So I mean, it's a land grab. I've got to just call and fax, and whoever says yes, that's boom, that's where I go. And so that's where the inefficiency, comes in. So if we go to the next slide and we look at, the goals of the players here. So for the emergency room, typically their goal is they want the patient to go to the appropriate level of care, and they want them there headed that way as quickly as possible. They're not concerned exactly where, we want to stabilize, find the appropriate level of care, and get them out of our emergency room. On the inpatient unit side, they want the appropriate patient. Given the fact that we work with so many ERs, in the last 2 months went around and met with a number of directors of inpatient units and simply said, hey, we work with 12 out of 13 closest referring hospitals to your inpatient unit. We'd like to keep people close. What can we do to work together to make this happen? Before you admit a patient from the other side of the state, can you call us and see if we have a patient at one of those hospitals? What can we do? And it became very clear very quickly that inpatient units are not concerned about where the patients come from. I mean, even to the point where I asked one, scale of 1 to 10, how important is it that this patient is relatively close to your community? And I said maybe a 1, maybe a 2. Essentially all they're concerned about is I have a bed, I want an appropriate patient for my unit to fill that bed. I'm not concerned about where they come from, how they get here, I just need that patient that's appropriate for this bed. And so that's really where the challenge comes in. You've got an emergency room that I want somebody out quickly, and an inpatient unit, I just want somebody that's appropriate for my bed, and then there's this group that gets stuck in the middle. And on the next slide, you know, that group is, A, the patient, you know, they're just kind of stuck. The magistrate and the court system gets kind of stuck in the middle there as well. And then, of course, law enforcement, right? I mean, they get really frustrated about, okay, why am I driving, you know, all across the state? And heck, I can meet my colleague for lunch at some diner, right, who's driving the opposite direction, you know, from the other side of the state as well, because we're just crossing paths all the time. You know, and it's a lot of frustration. I was in Alameda County yesterday talking with their officials, and you know, the frustration level there is really high, and why it is this way. And so on the next slide, and again using that example, one of the first things they asked me was, Doug, we're making more trips now to Council Bluffs than we are to the closest inpatient unit, which is in Dubuque. And so I explained to him, here's why. I mean, it really is pretty simple math. And here's a breakdown of where, you know, our placements have gone of the 2,500 cases. And if you look at comparing the two counties, Pottawatomie County and Dubuque County. So Pottawatomie County, on this slide here, has a population of 93,518 people. Between the two hospitals in Pottawatomie County that have inpatient mental health beds, there's 61 of them. So if you do the simple ratio of population to mental health beds, it's a ratio of 1,533 to 1. And 27% of the placements we've had have gone to one of those two hospitals. So now if we make a comparison to Dubuque County, which has almost an identical population, 94,648 people. However, they've got 29 total inpatient beds between their two hospitals. So they've got the same number of people, half as many beds. And as a result, you know, that ratio is double, and we've placed 1.3% of patients there. So it's really a bed capacity issue as far as where the beds are distributed across the state. And what this information tells me is that they're filling those beds essentially with their own patients that come through their own emergency room within their own county. And so it's all a race to these hospitals that have got excess capacity, which the one that has the most excess capacity happens to be the two in Council Bluffs for that. And to further demonstrate that point, if you look at Des Moines County, we work with the hospital in Fort Madison, and they pose the same question. You know, we never send anybody to Great River, it's just one county over. Well, if you look at their ratio, again, they have 8 beds, population of 40,000, you know, their ratio is even higher than Dubuque's. We've placed, I think, in 3 years, maybe 4 patients at that hospital. And again, it's not because they don't want to take them, it's a capacity issue. And so there's, you know, then just a quick comparison of the 3, you know, on the next slide. And really the takeaway is the inpatient units that have the most capacity are the ones that are going to be able to admit the most patients from other counties and referring hospitals. And so that's really where it comes down to, you know, how do we get to where we can start to place patients, you know, closer. I mean, so we don't have people, you know, traveling all across. And so we just did a quick analysis, again, using the same formula of, you know, population to bed ratio. And again, focusing on that 80% that has a very predictable path, identified that, you know, you could essentially do it in 5 placement zones to where, you know, based on each color, those hospitals within those colors wouldn't have to travel any further than that distance on average to meet their need. And again, don't get hung up on kind of, you could draw the lines and make these zones probably 20 different ways. But just to give you a sense that, you know, there is the capacity to take care of some folks. It's just the way the system is built and how it's done today that creates the challenge. And so I think the big question is, so how do we get from, you know, the current process here, you know, and again, this is based on that same example from earlier of us placing a patient, the one from Osceola and the one from Manchester. So we made 111 calls to get that patient from Osceola placed, and we made 122 calls for that patient in Manchester, because again, the way it's done is you have a patient, you're constantly calling, right? And you call an inpatient unit and it's, we don't have any discharges yet, but give us a call back in a couple hours, or you got to call back and follow up, so it's just, that process. Whereas we could get to a system where, if we're allocating resources differently, where it could really be focused on, zones and trying to keep people local and focused on just the resources that are available. And so I know the state has certainly taken some steps in trying to achieve that. I think one of the big things that they did was, the care match system, where inpatient units were expected to report number of beds, which is certainly a great start. The challenge and the limitation in that is a few things. Number one, it only gives you a picture of the beds available at one given moment in time, right? So I report, here's how many beds we have. 5 minutes later, somebody comes through my emergency room. Okay, that's outdated. The other issue is that it doesn't address the bottleneck, right? The bottleneck is I've got to call each inpatient unit, I've got to present a case, I've got to fax you 50 pages of documents, and then I've got to wait 2 hours for a response. That's where the bottleneck really lies, and that's where the challenge is. And then the third piece is it misses the patient factor. Okay, it's great to know where the beds are, but you can't really make a match or a connection if you don't know where the patients are and what level of care they need with that. And so, and then the other factor in it, of course, is, and I don't think this is news to anyone, but, again, you're dependent on the information being updated on a regular basis, and there's still times where that's a challenge. And I just took a screenshot of my computer 2 days ago, with an example of that. So with our system and the service we're providing, we've developed a software platform and solution that we're utilizing today primarily internally, to identify where the patients are and how do we get patients placed, right? And so, and this is just a screenshot of the platform that we've developed that demonstrates here's the patients, here's what level of care they need, here's the process that they're in. So we know here's the patients, here's where they need to go for that. And so we have it all centralized into one database for the hospitals we work with for that. And on the next slide with the screenshot, what we're able to store is we've got patient demographics, we've got the assessment that's been completed by our psychiatric provider there, so we know that they've been seen by a mental health professional and that they are appropriate for this level of care. We've got the lab work there from the hospital to get them admitted. We've got the ER doctor's notes, the nurse's notes, all the commitment documents from the magistrates we have uploaded into one system. And then we have all the hospital information, right? We know which inpatient units are in the state, who accepts which patients, what their admission criteria is, how many beds they have. And then we've got a log where, we can track all activity that happens and calls and so forth. And then ultimately we see the results as far as case length and so forth with that. And the next phase, and this is what we've just finished the development on, and we're going to be rolling out next month, well, probably later this month, probably in about 2 weeks, where we now, instead of having to fax all this information, are going to be able to give inpatient units access to our database. So when we contact them and say, hey, we have a patient in Newton, Iowa, and Skiff Medical Center, and they say, well, great, send us over the information. We can just give them a single login, and they'll have access to all those documents right there. Because, again, there's a huge delay. I can tell you, personally, our company spent $15,000 in faxing last year. Talk about an outdated technology, right? So this should speed up and help address some of that bottleneck with that. But where I think the real opportunity lies is if we're able to integrate what the state has already started and some of the work that we've done by integrating, our system with, the CareMatch platform or data. So now all of a sudden we've got a more robust solution for both sides of it. We're able to track, here's where the beds are at, here's the patients, here's the criteria that each inpatient unit has, and now all of a sudden if it's all centralized, we're in a position that we can start to look at it and say, okay, instead of sending the person from Manchester to Council Bluffs, we're going to send them to Waterloo, and the person from Osceola is a good fit for the inpatient unit in Council Bluffs, and we can start to, really address, the challenges and the frustration of those that are constantly being stuck in the middle with that. So everything being a single platform, and you get a dynamic look at what's happening. I mean, it's not a stagnant one glimpse for that. And so ultimately what that would look like, on this next slide is, it'd be always evolving. It's instead of today, it's the patient is sort of the hub, and all the spokes are the 120 phone calls and faxes that we have to make and send out. But instead, you have to look at it differently. It's instead of looking at how do I get a patient to a hospital, it's here's the inpatient unit that has beds, how do we get the right patient to that inpatient unit? And it becomes the hub, and we start to build it out based on that. But really the only way that can happen is we have to have a centralized placement system, because otherwise, if everything isn't centralized and managed in one area, you're still going to have this whole challenge of I've got 60 different hospitals calling about 60 different patients, and it starts to become very challenging and difficult to manage for that. And so the benefits of that is certainly would start to optimize patient placement, patients staying local, quick decisions, reducing travel costs. All documents are located in one area, and most importantly, we start to have analytics and data that we can look at, we can track, and maybe most importantly, it creates accountability. I mean, we can look and see specifically, okay, the X, Y, and Z hospital opened this case at this time and looked at these documents, and we can start to analyze, okay, well, why does it take 2 hours to make a decision? Maybe that is the appropriate time. I don't know, or, is there ways that we can reduce that as well? So it really starts to create, a more robust solution that does have accountability to it. And the way we would, foresee it is that, an inpatient unit would have to indicate that, hey, I've got X number of beds before, they look at cases. Here's cases that need to be placed. Okay, well, before we give you a case, how many beds do you have, right? I mean, if you've got 2 beds, there's no need for me to send you 7 patients, right? You can only take 2. But the way it is today, it's just fax me everybody, I'll just look at every patient, and now all of a sudden it's, this one, probably is a good fit, this one's a good fit, and, again, 80%, it's a predictable path. It's just a matter of, we've got to get them to, the right facility that's local for that. So, in closing, our proposal is, that the state would implement, a statewide placement system, by integrating CareMatch with our platform. And then I certainly don't want to discount that other 20% that are more complex and the path isn't predictable. But what it would give us is it would give us the ability to start to collect data. We can work with DHS, to start to continuously improve that process. I mean, those are the ones that you guys are getting phone calls on, where it's, this patient's been in my ER for 4 days, we can't get him admitted, and we deal with those multiple times a week, and when it gets to that point, our process is, okay, we call the region, we call the MCOs, we start calling legislators, we call DHS, we just call anybody and everybody just hoping, something happens, and, probably more than half the time, all of a sudden a bed becomes available. So I think that's where, by having a more efficient, streamlined process for that 80%, it then allows us to start to concentrate on, okay, well, what do we need to do with this other 20% so that we're getting them the services that they need? So, I can open up to questions from there. And again, thanks for the time and the opportunity today.
Good, thank you, Doug. I appreciate your presentation. I think we have a few questions to start off with. First of all, let me kind of bring it full circle for the committee. So why this presentation when we're talking about funding issues? And the reason for this presentation is because we have many different pieces of the system that are moving out there that we're trying to solve with how we're going to make decisions related to what a sustainable funding source is. And perhaps this is one of the greatest conversations I've had over the interim the most with people is getting the patient in the right bed at the right time in the right place. And so the reason for the presentation is to have that so you all are aware of what's going on, and so that we can then, as we're thinking about sustainability of funding, we're also talking about logistics, we're talking about travel, we're talking about law enforcement. We're not just talking about that mental health provider in this discussion. See a lot of heads going up and down along the lobby, so I think we're making a connection here, it looks like. Let me first ask Doug, how have you, well, let me back up. You mentioned at the beginning of your presentation about funding issues, working with departments, trying to figure out how this program would be sustainable and moving forward. It appears that there's an amazing amount of data that you all have been collecting as it relates to the patient population in the state of Iowa for mental health. Correct. My first question is, can you talk to us a little bit more about the funding past and funding future without reaching any conversations that you're not able to talk about if you've had any with the department?
Sure. So, yeah, so first of all, I haven't had any direct conversations with DHS. The way our service is funded, majority of our service is funded, it's not entirely, but the majority of our crisis services is funded, is the mental health regions have stepped up and said, hey, we will fund this to make this available in their hospitals that choose to have the service there. And most cases in those regions, I'd have to go back and look at the numbers, but certain regions we're absolutely working with 100% of their hospitals. Others, it's 90%. So I would say it's probably 90% of those hospitals within their regions that are taking advantage of our services for that. And so essentially the regions are just paying us on a per case basis. So the number of cases that we have, they pay us on a monthly basis for those patients that we manage. And we base a case on from the moment we're contacted until that patient is discharged from the emergency room. So whether they're discharged and transferred to an inpatient psychiatric facility, or if it's to a substance abuse facility, we work with a number of them as well. Or whether they're discharged to an outpatient provider. And so the challenge on the funding side of it is they're, of course, as you guys discussed earlier, concerned about, what does their funding look like in the future. And so the conversations that have come to us from the regions is that they've encouraged us to start to look and explore if there are other funding sources, given the uncertainty of their own funding, that, they're not certain that they may be able to fund it in the future, especially given the increase in services that they're now going to be required to deliver for that. So what we've looked at from a funding standpoint, the MCOs, of course, and I think our service is unique in that we're combining a couple of things, right? There's certainly the assessment side of it with, our doctors, but then there's the whole placement side of it. And then we also make our providers available for reassessments, for additional consultations, while we're managing that case. Well, if we go to just a traditional fee-for-service model, you only get paid to see the patient one time while they're in the hospital, right? So our psychiatrists would only be incentivized to see them once. And number two, they'll get paid the same amount if they see them at 2 in the morning as if they see them at 2 in the afternoon. Okay, so as a doctor, why am I going to get up at 2 a.m. to see a patient when I'll get paid the same if I say, well, wait and see them at 8 in the morning? And so that's where, again, the expense comes into what it takes to, hire a team that's available around the clock and that's available to see people multiple times. So that's where the challenge really lies, is that, the service we're providing doesn't fit perfectly into, the way services are being paid for today. And that's been kind of intentional on our part. my approach and our approach is, you know, let's figure out how to solve the problem, and we'll kind of figure out the funding piece through that, and demonstrate that, hey, this works first, and whether right or wrong, I kind of believe the money will eventually follow at some point.
Thank you for that greater clarity on the funding piece. Let me also then ask you, with the data that you presented to us, has that been presented anywhere else besides to us, or has it been delivered to DHS? Do they have access to this, I guess is my question.
We deliver very similar data and information to the regions, so I can't speak to if they forward it on to DHS or not.
Okay, good. I believe this is some pretty significant data that would be important for DHS to take a look at as well, so I'll be recommending that DHS and you all connect and get a meeting established so that they can see some of the data that you have available to report back from a statewide perspective. Because as you said, you're in 77 counties, that's to some level. I think that's a key, you have some key information for us to all have at a state level. So, good. I'm going to hold other questions for just a moment. Representative Carlson and then Senator Costello.
Thank you, Mr. Chair. I have a couple of questions. On slide where you have 77 counties in the remaining counties that you don't or have not had service with, is there a reason that those counties don't do service? Because I was looking at it compared to the region maps, and there's not really a clear correlation between regions and counties not serviced or whatever.
Sure, and I can tell you on the service side of it, that encompasses all services that we provide. So for example, we don't have an agreement with, you know, a given region, but we may work with the community mental health clinic in that region. They may contract services through us to our psychiatrists. So we've included that in here for that. So that's why there's a little bit of disparity between the regions for that.
Okay, and then as a follow-up to that, on the slide where you have the bullet point, 9 of 14 regions are paying 100% today. What exactly does that statement mean?
So what that means is for our crisis service that I described, 9 of the 14 regions, we have a contract to provide that service to their hospitals. And so in their region, the region is paying 100% of the cost. They're paying us. So for example, in the Central Iowa Community Services region, we see patients in all of their emergency rooms. They pay us directly for the patients that we see in their ER.
So in the remaining 5 regions, then you're getting paid by a particular institution that's within that region, or how are you getting that?
Correct. So the other 5, there's 2 hospitals that we provide services to, and the hospitals are paying us directly for that.
Okay, so you're contract with a provider.
Correct.
If you're not with the region.
Correct.
Okay.
And now I can tell you, and clearly the uptake has been significantly higher in the regions that are paying for it than,
sure.
We've spoken with every hospital in the state, I'm certain of it, and we're working with 51 of them. So if you take, roughly the other half, there's I think 120 hospitals in the state. You exclude the ones that have psychiatric services already, the other half, there's only 2 of those that, are funding the service directly. So.
All right, and then my final question. Is there anybody else in this market space other than you? Are you the sole provider of this service in the state of Iowa?
There's other companies out there. There's a couple of national organizations. To my knowledge, we're the only one that provides this encompassing level of service. And again, I attribute that to probably the fact that we are in Iowa and have established these relationships. But other organizations, primarily what they do is just the psychiatrist side of it, where they'll have a psychiatrist available to do an assessment, determine appropriate level of care, and then from there it's, this person needs to be hospitalized. And that was the model we started with until a number of emergency room nurses said, well, that's great to let us know that they need to go to, a mental health bed, but can you help us find the bed or get a bed? And so that's really where our service evolved from. So there's others that will certainly connect in and do consultation for that, but to my knowledge, we're the only one.
Thank you.
Senator Costello.
Thank you, Mr. Chair. Thanks, Doug, for coming and presenting to us. This has been really fascinating for me, and I think it's one of the best understandings I've gotten of how this is all working and what the problems are. And I definitely can see a value in creating a integration of Hugo and CareMatch. Do you have a feel for how difficult that would be and how expensive that would be and what all would be? Would you want to do that if we gave you permission, or do we need to have the state work on that? Or I'm wondering about how that can be accomplished.
Sure. Yeah, I mean, we would certainly be up to doing it. Knowing exactly what it would take from an integration standpoint, we'd have to have more information. I mean, I don't know the back workings of CareMatch and all of that. So it would probably be an analysis of what's the cost to integrate, or, you know, it might be less expensive to just sort of develop a similar feature that CareMatch does. We'd have to have some conversation to get a better understanding of exactly what that would look like.
Okay.
And then certainly get kind of some rules and processes in place to make it effective. You know, again, the only way I can see it being effective at this point, and there may be other ways, is really it's got to be an understanding for an inpatient unit that, hey, here's how many beds you have, and, you know, here's patients that are available, and then as patients are placed, those beds kind of come off the board and so forth. And I know some of the challenge has always been, you know, the administration time and so forth, but again, I believe that by us making the system more efficient and eliminating that bottleneck of having 60 hospitals call one inpatient unit, if we can eliminate that, it should free up enough time that you can report, here's what we have for available beds.
Yeah, and that kind of brings me to my second question. You know, you're making all these calls, and then the first one that gets back to you, you say, okay, we'll send them there. Do the hospitals and places, they get tired of saying, calling back in, and you say, well, I've already got them placed too? I mean, I can see a real problem here where people are just getting, on both sides, frustrated with the volume and say, you know, it's like, well, they look through there and figure it all out, and then they call you and you say, well, I've already got them placed, and that would de-incentivize them to do that. And
it absolutely happens. I mean, we call back as soon as we get somebody placed. We then have to make calls back and say, hey, we got this patient placed, you know, but hey, we've got this. We do, you know, and we do it more from an opportunity of, okay, I know you've got a bed now, right? If you're looking at our patient, at least in theory. So we view it as an opportunity of, okay, well, hey, we got this patient placed, but by the way, we got this other patient. Would you take a look at them? It'd be a whole lot more efficient if we just said, hey, we've got two patients. This one is closest to you and they meet your criteria. You look at this one, and we got the second patient. We'll send them over here, and you look at them and go that way versus, hey, let me send you these two and let me send you these two, and oh, great, you both selected the same one. Now we got the other one stuck in the middle, and so it's a frustrating process.
So from looking at it from a business aspect, you've got these providers. Are they actively wanting patients, the ones that have beds? Or is it in their best interest to have these beds filled? Or are they're like glad to get, or is this something like they're like, I've got so many people that I'm just trying to shuffle them?
It became very evident to me early on, and so when we first got started, we had limited resources, being a still relatively young company. So it was myself and another individual, Nathan, that works with us. We had two patients. I was working on this complex patient, and Nathan had this other patient that, again, had a very clear path. And the phone was ringing off the hook to Nathan for this patient. I couldn't get anybody to talk to me on the phone with this other patient, right? So the answer to the question is, for that 20%, inpatient units would rather let a bed sit empty versus admit certain patients. But for that 80%, yes, they're happy to get the call. Now, I don't mean that in a bad way in that 20%. It's certainly not that I don't think they don't care, they don't want to help, they don't, there's something there, right? So if someone's aggressive and assaultive, it's okay. Am I going to admit them and let them assault my staff? No, because now all of a sudden that creates liability issues for them. So it's the intention isn't bad. It's just they've got other factors that they've got to take into consideration. That the potential risk of admitting this person is probably greater than the reward, right? And so that's really what I think it stems from. It's not that I don't care, that I don't want to help or take care of somebody. It's just the risk is too high.
So that brings up my next thought. I think this will help, but we still have this 20% that's hard. And I think that you have to compensate them for the added risk, and we have to find places that will specialize in that can deal with it, that are prepared to deal with it. And I guess that's maybe our big challenge that we're fighting with, and trying to figure out how to fund that and reward people that will take those difficult patients.
Well, and I believe that before you can do that, you've got to get really efficient and have a really solid process for the other 80%, right? To where the 80%, we know exactly what's going to happen and this works out great. I think what makes it difficult is it's all thrown in together, right? And now all of a sudden it's okay, you got to deal with this person that's complex, and here's this other person, and okay, so where do I spend my time? Do I spend my time it's going to take me, it absorbs hours with, the complex person. So what happens to the other person? Well, they're kind of sitting here on the sideline because I got to deal with this. And, so that's where I think it's got to get really efficient with the 80. So then it allows you to really concentrate and say, okay, well, who are these 20%? What is it they need? How do we get the resources in place there? To me, I think that's where you build a really solid system.
So do you think there's situations where the 20%er could be placed, but it's just we're sitting the easy ones there, and so the beds aren't there because,
I do believe that. So I'll put it in a different context, but it's the same. It applies the same. So there's 3 inpatient units that specialize in geriatrics. All they admitted are geriatric patients. Okay, well, virtually every adult inpatient unit will take a geriatric patient. So what we've coached our team to do is anytime we have a geriatric patient, exhaust the geriatric units first, right?
Mm-hmm.
Because if they have a bed, let's get the geriatric patient there, right? Let's not take up an adult bed with a geriatric patient because the geriatric patient has an alternative place. The adult patient doesn't. So it's kind of the same. If we look at our data, we can identify there's, a handful of hospitals that, deal and manage with these complex patients much better than others. So let's identify that and let's get them there because that's, where they're going to see the most benefit with that. So I do think there's opportunities. It's just going to take some time to kind of get a process going, and you got to start tracking and see exactly what that is.
Okay, well, I just want to thank you for coming again, and it's really encouraging to know that somebody's out there really thinking about this and working on it and trying to get it. And I guess I'd want to say that I hope we will be able, anything you need from us to do to help facilitate that, we'd love to try and help. So.
Thank you, I appreciate that.
Senator Segebar.
Thank you, Mr. Chair, and thank you, Mr. Wilson, for being here, and we're going to share both these microphones.
Okay.
I don't know who I'm going to be looking at. You have been living the problem we've been trying to solve here for 6 years, and that's bed tracking kind of an issue. You bring a lot of confidence. You speak from the heart about these same subjects that we all been stirring the pot in for quite a while, so thank you for being here very much. Would you consider ITP to be there's core services in regional mental health. I think there's 17 of them. And which one do you think you fit in? You're kind of the crisis stabilization, but you're really not that either. Your bed tracking is really what you are. Is that the biggest part of the service that you give to those 77 counties? Are they hiring you to help find a bed? Is that, would you say?
No. Yes and no. I think part of the challenge is sometimes, think we try to define everything into, you know, what is this and what is this, right? And it's like, okay, well, if you combine it and bring it together, you have a more comprehensive solution, right? So unless we have the psychiatrist, right, that identifies and knows, okay, this patient is appropriate. I mean, there's been a number of patients that we've seen in the emergency room where all of a sudden their potassium levels are low, and we get that adjusted, and they are discharged from the ER and they go home, right? If our doctor wouldn't have been there and looked at that and helped assess that, people would have been calling for inpatient beds, and they would have gotten to another hospital, and they would have said, great, we did lab work, their potassium level's low. We got that adjusted, and send the sheriff back to come get them. You know, and so without it, you almost need one in order to do the other. And so I guess that's my reluctance of saying that our value is just one.
Thank you. Second question, we've added 3 new core services with the legislation last year. And if this region set these up, how will they help you? One would be access centers, which is for crisis and then the second one is assertive community action teams that would do individualized treatment, which is sort of where your psychiatrist, telepsych is actually starting that process. It just is recommending where they should go to the next step.
Well, assertive care treatment teams, ACT teams, are a little bit different. And we work with an organization that has 3 ACT teams, RHD, and they do a great job. But those are really more of an ongoing, long-term team that somebody's a part of. They certainly have to address their clients, you know, when there is a crisis, but they're not coming onto the team when they're in a crisis situation. It's somebody where that crisis has already, you know, been managed, and they need just a high level of care where someone is having, you know, regular touch points with them. So yeah, I'm not exactly sure, and I guess that's where, you know, our approach has been different, is that we've just tried to say, here's the problem, here's the solution, let's go out and put together a service that solves it, and not worry so much about how's the legislature, whomever, how are they defining things.
Yeah. Okay, so you basically work with hospitals. These are
correct.
All the places you call are hospitals.
Well, hospital, yeah.
So there's the third core service is called intensive residential service homes. Now, I don't expect you to understand what that means, because I'm not sure I don't understand what it means, but I would classify this. I have a small regional hospital in my district, not too far away, in Manning, Iowa.
We work there.
Has a 28-bed residential facility that they can be there as long as a month to get them their meds straightened out and all that good stuff. And I think that qualifies as an intensive residential service home is what I think that does, but maybe not. I don't know. That's why I'm asking you the question.
Sure.
So the services that the regions are going to add, will that improve or make your job a whole lot simpler in the end? And nobody knows the answer to that question. But
right. I think the challenge for the regions here is that based on the definition of the services that they're adding, our service doesn't really fit into that. And I think that's where their concern is from the funding side of it, is that, you know, we have to provide these other services, which, you know, if they've got some uncertainty on what their funding looks like, that may put them in a position that they've got to cut or eliminate some other service. And I think that's where the concern is that they voiced to us, hey, here's kind of warning that, you know, we think it's valuable and we certainly want to continue it. So let's figure out and work together what we got to do that, because we might get in a really bad position in 2 years if we don't start working on this today.
So in the case with Manning, I think that Rolling Hills region actually contracts for a few of those beds to be available. Last point is, are all your psychiatrists licensed in Iowa that do the telehealth?
Yes.
And I just want to add this out. I spent a considerable amount of time getting brought up to date on the Psych Pack, which we don't have here in Iowa, but there's several states that are about to create enough that you could have psychiatrists from out of the state provide their service, and would that be a big help for you?
Yeah, so majority of our psychiatrists don't reside in Iowa. They're all licensed here in Iowa, but the majority don't, and that was intentional when we started the company, because if we don't have enough psychiatrists in Iowa today, just recruiting and kind of poaching from each other doesn't really solve the big problem, right? So our focus has been, let's go to, you know, large communities that, you know, I mean, we've got, our medical director lives in Cleveland, we have a psychiatrist in Los Angeles, we have a psychiatrist in Atlanta, we got a whole bunch in Florida. So, you know, we just focus on where are the doctors at and let's bring them to the state. And that's been our approach.
Thank you, Doug. Thank you, Mr. Chair.
Thank you.
Thank you. Thank you for your presentation. Do you think we have enough adequate beds in the state of Iowa?
It's a good question. I'm not sure I know the answer to that.
We have a lot of data, so I'd say that.
Here's what I believe, and again, this is just my opinion. I believe that you're going to have as many beds as the marketplace pays for. So I think for that 80%, it's probably pretty close. So are there days that there's not? Yeah. Are there days that beds sit empty? Yeah. I think the challenge is the other 20, and again, you kind of lump them all together. That's what makes everything messy.
It's a hard place to find places like. So when you do that, you have to go through an MCO to get them. So you have hospital A that'll take them. Do you have to go through an MCO to get them prior authorized to do that? Is that
we
your
don't. We don't have to deal with the prior authorization side of it.
They're already pretty
right. Yeah. So typically through EMTALA and all of that, we haven't found funding to be a huge barrier to getting patients placed, as far as an inpatient unit being willing to admit them. On the mental health side, I can tell you on the substance abuse side, it's totally different. That's a major barrier, and those folks sit in the ER. If the average time is 5 hours for a mental health patient, the average time for a substance abuse patient is like 3 days. They sit there forever.
So when you get someone in a facility and do you have anything to do with getting them out? Is that part of your role?
We don't today, no.
So you're just mostly initially getting them into a facility and then first part. So in my area, we've had people that we wanted to move to someplace else. Then also, what about out of state? Do you put a lot of folks out of state, or do you put them all in Iowa?
We place folks in the neighboring states. And again, you know, our goal is let's try to keep people local. And I've always looked at it as, okay, if I'm the patient, I just want help, right? I don't care what the logo on the hospital is. I don't care about this invisible state line, right? I just want help. So
what about costs?
So, I mean, costs on the challenge with out-of-state placements is you know, we had this is an example we had where a Mayo had agreed to accept a patient. The patient got there, and then all of a sudden, Mayo in Rochester said, "Oh, we don't take Iowa Medicaid, so you got to take this person back." You know, so that's where it does get to be a challenge.
That's what I'm saying, the system sometimes.
Yeah, so certainly if they're not in a network, it can pose a challenge, but you know, and then there's the challenge sometimes of like involuntary commitments, and okay, if this person is committed to a hospital in La Crosse, okay, does that magistrate really have jurisdiction? And
right.
You know, so it gets a little messier, but we do it, and we've been successful in placing a number of folks in other facilities. And I look at it again, if it's me or a family member and I knew, hey, you go from here to Omaha and you're guaranteed to have a bed now versus you're going to sit here and wait for another 8 hours and maybe you'll get one in Iowa, I'd be taking my kid to Omaha. I wouldn't think twice about it.
Well, I think family members are looking for the right services.
Right.
And not just an open bed, but they're looking for the right services, especially if we're talking anybody, you know, is really having a close family situation. That would be my thought. Then, do you have staff in the hospitals then? Where's your staff? Are they located in the hospitals or?
Our staff
Tell
is
me how
in.
it works then.
Yeah, so
It's
how it
so
works
weird.
is an emergency room logs in. They enter in just basic demographic information, patient name, address, and so forth, and then they upload all their information from their EHR, so face sheet, nurses' notes, ER physicians' notes, lab work, and our staff that's on 42nd Street in West Des Moines then assigns the case to whatever psychiatrist is covering. Right now it's Dr. Aaron Albert, who's in Wilmington, North Carolina, and he sees the case. A robocall then goes to the emergency room that says our doctor will be ready to see the patient in 15 minutes. They wheel the telehealth cart, log in, our doctor's on screen, does an assessment. He then calls the ER and says, I saw this patient. I think the appropriate level of care for this patient based on my assessment is they need inpatient psychiatric hospitalization. You know, do you agree with that? 9 times out of 10, the ER doctor says, yeah, I agree with that. Great, we'll have our patient advocate team start working on placement. He finishes his note, notifies our patient advocate in West Des Moines electronically. They start calling all the inpatient units, and there's a live call log that the ER can log in and see at any time, so they see who we've called, who said what, who has beds, who doesn't have beds, who we faxed information to, until the patient's placed. And when they're placed, the inpatient unit will call and say, you know, we're able to take X, Y, and Z patient. We then connect to a 3-way call to the ER and have both nurses on the line. They do the nurse-to-nurse handoff, and we then close the case, send them a summary report that summarizes everything that's been done, and ask that they click and sign off on it, and they have the opportunity to rate our service. So that's what a case looks like from start to finish.
Okay, and so once they're transported, you're done? That's
Correct.
it? Have you been working with the hospital association? Because as the two senators alluded to, that we've been talking about bed tracking for some time. So the hospital association, are you working with them?
We've been having conversations.
They've been very involved in wanting to solve this problem as
Right.
well, so.
Yeah, we've been having ongoing conversations with them, and are now an affiliate member with the Iowa Hospital Association. They've been very instrumental and supportive of our service. And what
I would
we're
think
doing.
they would be interested in where this moves, so. And there's no other company in the state of Iowa doing this, you're the only one?
We're the only one that's located in Iowa. I know there's a couple other, like I said, large national companies that are doing, you know, like ER consults or some other
Or substance
consultation.
abuse.
Something similar,
Something
but
that they can't
nothing
afford
not
a
as
psychiatrist, they're using telehealth from someplace else.
sure.
So I'm sure that we have a bidding process that we're
Sure.
trying to move forward on. But thank you for doing the
Yeah.
presentation, it's very enlightening.
Thank you.
Senator Bolton. Thank you, Ms. Chair. Thanks for the presentation. It's been
Yes.
really interesting. So you talk about the 80-20, the 80% that are maybe a little bit more cut and dry for placement, the 20%. What are the characteristics of the 20% versus the 80% that make them more difficult?
Typically, if there's intellectual disabilities, those are always a challenge. And many times that 20%, I'm just trying to think of specifics. You know, there's one that we've had who she has a disorder of swallowing objects. And when I say objects, like scissors and things that we probably could never imagine trying to swallow. And so literally somebody has to watch her at all times. I mean, she swallowed stuff in the emergency room, right? And so that just takes a much higher staffing requirement
So
than...
the challenge is the placement. That she may have this swallowing problem, but one of the challenges, so it's difficult.
Correct, right.
But,
and
but
it's...
who's the provider where's the bed, right? I mean,
right, it gets down to who has that.
Where is the bed for that patient in Iowa?
I think that patient wound up at one of the 2 MHIs. I think she's been through the ER multiple times. She ended up at the university, I think, one time. I mean, one of the other ones is, so the most recent one we had really wasn't a mental health issue as much as a placement issue or sometimes it's housing issues. I mean, a classic one, the longest one we ever had was a 12-year-old who his parents brought him in, and this was in Elkader, Iowa, and he had a severe intellectual disability. Mom and dad realized, we just are no longer capable of taking care of him, and they filled out all of the paperwork and everything. Okay, well, he needed to be in, a facility to get him stable, but now all of a sudden that's a challenge for that inpatient unit because there isn't a discharge plan after he comes here, right? He has nowhere to go. And so he's going to wind up on my inpatient unit for who knows how long, maybe months. And so, again, that's, their challenge is that we're only going to get paid for 3 or 4 days.
So that's, again, another situation where there's not a placement for that person. I mean, there are difficult ID islands, right, that we do take care of and figure that out. But
right.
This would be an example where there maybe wasn't capacity within the state system. I mean, that
right.
seems like
Yeah.
that seems like an obvious potentially person that might be at one of our facilities.
I guess I would agree.
We've had some contraction in that regard, which you may be aware of, I assume you are.
Right.
In terms of available beds. The assessment of the patients when they come in, before you brought a psychiatrist in, would just the ER doctor do the evaluation? It seems like you're bringing
typically
another level of value here potentially.
Correct.
And cost.
Correct.
Does everybody...
Hopefully the value is greater than the cost.
Sure, but but you're a recent entrant into Iowa doing this, I assume. How long have you been doing this?
5 years.
5 years, okay. Well, as you've seen from the reaction you've got, this has been an issue for a while. And I think do we have a state system? I think Rick Schultz runs a state system. Don't we have some software and some DHS employee that tries to help do placements too? I think, are you familiar with that or?
No.
Okay.
Never thought so.
Maybe we ought to get Rick Schultz ought to come in and tell us. I mean, we've been, Senator Segerbar, we've been working on this, right? Not as effectively as we all hope we could, but I'm interested in knowing kind of what's the status of the state's own effort in this regard. Does every patient have to be assessed by you, or is the emergency room doctor in some cases able to say, yes, this person obviously needs to be stabilized, needs inpatient, we don't have it?
So we offer 2 levels of service with who we work with, and that is if there's a patient that they feel, it's clear cut that, this person needs to be hospitalized, they can request that piece of it only, and we'll start working on that, and then we have our psychiatrist review the documentation. Now, we used to do that without the psychiatrist piece, and what would happen is, again, it gets to be sort of the path of least resistance for the ER. I mean, you have to keep in mind, what is their goal here? I want to get somebody out fast, right? So it's really easy to say, oh, call ITP and tell them to find a bed so we can get this person out of here. Okay, well, this person doesn't meet criteria, right? I mean, we can make as many phone calls as we want, but they're still not going anywhere. And then it's like, oh, ITP is not helping us. So, that's where we've gotten it to where we've got the psychiatrist involved, so at a minimum they review the case. If they've got questions or, sometimes there's, some documentation that is missing that could be added that will help get the patient placed. And again, it's more the peer-to-peer side of it where there's value, because if I'm a psychiatrist and I see a note from a colleague, I'm more likely to say, okay, this person really does meet criteria versus here's an ER doctor that I might be concerned just wants to get somebody out of their ER and thinks this is a quick way to do it.
So do you do transport?
We don't. No.
You don't do transport. So when you connect folks, the nurse to nurse, and that we're ready, who does that? Is that the sheriff's department? I mean, is it the...
It depends on the hospital and the region. A lot of regions have contracts with, a secure car transport service. Sometimes it's a sheriff. Sometimes it's an ambulance.
So how many patients a week or a day? I mean, what's kind of the workload?
We see about 300 cases a month.
300 cases a month.
About 10 a day. and it's growing.
Sure. Thank you.
Yeah, thank you.
Mr. Chair, I know that you're looking for a place to meet next, whenever we get together again, and I think it'd be fantastic if I'd offer to invite the committee to meet at the University of Iowa Hospitals and Clinics. I've got the UI psychiatry folks will be more than happy to give us a tour there, and also we've got a great facility to meet in.
You send a helicopter.
You guys were just in Iowa City. All
right, I'll bring the meeting back to order. Senator Adler, you are in order.
I'm out of order, Mr. Chair.
All right. Thanks again for coming. Presenting today. On your store case data.
Here, Michael.
Sorry about that. On your store case data, how did you come up with those categories? Is that something that's always used when you do patient demographics, assessments, labs? Is that kind of a standard array?
Yeah, so it basically was input from our medical director. In her background, she's specializes in emergency psychiatry, did her training at one of the busiest emergency rooms in Los Angeles. And she's been doing, we were fortunate to add her to our team, and she'd been doing emergency telepsychiatry work in 2 different organizations. Probably the largest study that's ever been done in South Carolina she was a part of, and this was based off of her experience that she developed, the standardized assessment, and then this is also based on the information that inpatient units need and require for placement. So, they always want to see the commitment paperwork, they always want to see lab work and so forth.
When looking at the bed tracking system and the database storage, how would you see that playing out at the state level? Would you be the only entity that's accessing and they would contact you to get that access, or would you have a centralized hub at some point to where anyone can access with proper security measures?
I'm a believer in transparency, and so I would think that we would certainly have different access levels, and depending on that access level, obviously we've got to be extremely sensitive to HIPAA guidelines and privacy and security and all of that. So based on the necessity of individuals seeing some of that information, but I don't think it should be a secret.
Okay, and lastly, one of the most important things I see coming out of a bed tracking or a centralized database would be that road mapping of outcomes, keeping track of the successes and the failures, so we aren't repeating the same processes over and over that have created failures, and making sure we're getting patients to the proper beds. I look at this more from the bed side of it, and you're coming in from the front end where you're actually assessing each patient. When I was looking at it, it was more of an acuity level of the bed, and I think there's kind of some grounds here to maybe look at bringing that together.
Right, yeah. I think the challenge with, the acuity level of a bed is it changes, it's dynamic, right? So it depends on who else is on my unit, right? So if I've got, really 2 or 3 high acuity patients on my unit, I may not have the staff and just the ability to take a 4th, right? So it may be a high acuity bed, but at this particular day, it's not. But you know what? 2 of those 3 patients are discharged tomorrow, and now all of a sudden I've got 2 more high acuity beds, right? So I think that's the challenge in this, is that it's a dynamic climate, and that's where you can't just look at one and say this is what it is and this is what we've got, because it can literally change by the hour.
Thank you.
Representative Carl.
Thank you, Mr. Chair. This slide that you had with the pie chart, and you showed that 40% of the patients were discharged with outpatient follow-up. Can you give me any feel for, with the introduction of the telehealth services, and some locations didn't have those until they began to contract with you, is this number 40% fairly stagnant, or would you have seen many more people being admitted prior to your services being available at a particular hospital?
I can't speak based on data. I can just speak, because I don't know what the numbers were previously. But based on feedback that we've gotten from emergency rooms and hospitals, I would say yes. I think the number would have been quite a bit higher. That were going to the hospital.
Thank you.
Are there any further questions from the committee at this time? If not, I have a couple of other comments, or one question, one comment. So Senator Reagan brought up the notion of the number of beds in the state, and my understanding is within Des Moines we'll have 100 beds coming online. In Bettendorf will probably, I think it's 72-ish beds coming online. From your perspective, with kind of a statewide view of understanding where the beds are all at and sending patients back and forth in different directions, are those beds placed well? And are those beds going to be utilized in a way that allows transportation distance to be reduced? I know I'm asking you to predict.
Sure. The way the system is today, it's not going to, you still can't predict it, right? Because it's still a land grab, right? Whoever calls first and whoever gets swept first, right? I'm not going to say, great, you got a bed, but let me check back with these two other places that are closer. They're going to say, either you want it or you don't. And if you don't, I'm going to take the next patient. So I'm going to take the bed because I'm not going to run that risk. So I don't know that it should help because there's more in an area and it should help a little bit, but it's not going to solve the problem because, again, you're calling everybody and you're trying to get a yes if I'm an ER. I mean, that's the goal there with that.
My only other comment is we've talked a lot about that 20% complex needs set of individuals. My understanding is the tertiary work group, which is, by the way, one of the other work groups that our legislation authorized, they're looking at that complex needs set of population. So I don't know what outcomes they may come out of that work group in recommendations to that 20%, but I just wanted the committee to know that that 20% is not lost in the conversation amongst other work groups. And the only other thing I would say is I think the MHIs are also in the conversation in the context of that tertiary work group as well. So more to come from what they're doing on that side of the table related to this population. All right, so good. I am glad that you were able to join us today. Thank you for sharing the information that you have. Again, key in my mind was, as I was visiting, back to Representative Hedden's comment earlier in the day, as I was visiting with my own folks and others, and your name kept coming up as a provider or as a contractor that is assisting in a variety of ways. 72 counties you somehow have a footprint in. I thought it was incredibly important for us to be able to hear from somebody who has that large of a footprint across the state that's helping in this complexity of conversation. So, thank you, Doug, for your work with the state of Iowa. Thanks for coming to the committee today. We appreciate it.
Absolutely. Thank you, and thanks for the opportunity. Thanks for the time.
All right, so we are at the point of the agenda for committee discussion and planning. What I'd like to do, we've already had some statements earlier this morning around potential things for our next meeting, but I would like to open the floor up. Specifically, the conversation will be focused around what ideas, discussion, thoughts you have related to what the agenda might look forward to next time. Senator Moulton.
Well, I want to just reoffer the meeting space in Iowa City, should that be of interest to the committee. I think next time it'd be good to have a panel with our CEOs from the various regions to get an update, to get their view on their funding, especially their view on the continuation of the property tax levy. I think it'd be good to have Rick Schultz here as a presenter to give us an update on what's going on with complex needs legislation. It is probably the next big expense to the regions and the counties. Kind of get us, I think we need to have a better sense of the timing of when some of that expenditure is going to happen for access centers, assertive community living, or assertive community training, or treatment, I'm sorry, as well as the intensive beds and the subacute beds. I think if the regions have any concerns, it's about us directing them to spend money on these new core services. I think it'd be helpful to hear from them on how that's coming. I don't know if there are providers that we'd want to hear from. I mean, we are going to look to providers to take up the mantle to do these services, or at least get some sense from the regional administrators on their conversations with their local providers about who's going to step up and what they see the challenges and the opportunities there. And I don't know if we want to get an update from Rick Schultz on the bed tracking from his perspective, if we need to pull the plug on what he's doing, if they've got it covered here, or kind of get maybe it'd be helpful just to have a better sense of that. Thank you.
Other thoughts, Representative Carlson?
Yes, thank you, Mr. Chair. You know, the other interim committees, and you did reference one of them that's talking about that other 20%. You know, for us to also think about funding, somehow coordination of what they are seeing, what they're looking at, and if there's something that is going to drive additional investment or cost, you know, somehow we need to at least be in tune with what they are thinking about as we work on our recommendations for funding reform.
Other discussion from committee members for next meeting? Senator Segebar.
Thank you, Mr. Chair. As I was visiting with my local region at home here a few weeks ago, their biggest concern was spending their balances down. The second biggest concern was timely Medicaid payments. So I think this goes to Senator Bocum's concern here. We could hear from IME and that timely payment is very important on how all of this fits back together as providers come in and get contracted with. If you can't guarantee you're going to get paid within 30 days, I don't see how they can even start down the road. So, thank you, Mr. Chairman.
Thank you, sir. Representative.
Thank you. I think I just want to echo what others have kind of already said in regards to having the regional folks come in, having Department of Human Services and IME and some providers come in. I mean, I've read over the charge of this study committee here about 20 times in making sure that we are analyzing these funding streams. And I want to make sure that we are looking at that viability. Is our current system viable? I mean, if we've got a report that's due to the General Assembly by January 15th, that's a lot of data and a lot of information I think that we want by the next meeting to be able to write something up and say, so I'm just trying to wrap my head around of, okay, who else do we need here so that I know, is this a good funding system? Are the calculations correct? What are their suggested recommendations? Why do they recommend that? Is the per capita expenditure amount accurate or not? How does it fit in with the managed care companies so that regions aren't having to provide additional cash flow, and the impact of the fact that counties or regions have to reduce their fund balances down to 20 or 25%. That's a huge impact when you tell them, hey, we want you to expand our delivery of services or availability of services. But by the way, we want you to spend on your funds at the same time. And how do you do that when they don't have a levy rate that they can increase as well to meet all of those demands?
Just a quick comment, because of all the information Doug just gave us, I really would like to talk to the regions and talk to them about how his idea with the zones fits in with the regions, because as he showed us today, reducing the travel time, the time spent in ERs, the ER visits, and one of my main focuses is actually the patient care and the patient treatment plan. Because I work with those folks in my area. So really visiting with the regions and how does the zone idea fit in with the regions and how does that maybe need to change or differ? I think we need to explore that because there's some cost savings there that Doug brought up. And for me, there's some patient care that got brought up that I'd like to see. Thank you.
All right, thank you, committee. At this point, we've got many ideas. We will, as co-chairs, will be putting the agenda together, and we will also be getting out to you a couple of different dates to look at for the meeting, and so that will be forthcoming as well. I want to give a few... Representative Lundgren, yes, please.
Sorry, I just like to mention, I think including a county supervisor who's from a couple of different regions come to the table at our next meeting might give us a new perspective, or at least have a discussion about the reimbursement rate once the regions start picking up, because obviously that's a big part of the discussion in regards to sustainable funding.
Excellent, good, thank you, Representative. Sorry, I'm remiss in not having recognized you if you had any questions for either of the presenters. So we could bring the presenters back to the table and let you drill them for a while if you would like.
No, I think we're good.
All right. Thank you. All right, with that, let me give a few instructions for the afternoon. There will be a vehicle outside. If you don't want to drive over yourself and you'd like to ride together, there will be a vehicle at 12:45 out here at the Capitol steps. We will be going to visit the Polk County Health Services Crisis Observation Center at Broad Lawns, as well as the Crisis Stabilization Center. Again, those House File 2456, the Mental Health Services Bill, is all a part of the conversation for the afternoon and how it's playing out in its work in the communities. Once we get there, Sarah and Annie will be leading tours for us to have discussions with them through each of the locations, and to help us better utilize our time, we'll probably be splitting up into two groups so that we can get through both tours. The intent is that we would be done by 3 o'clock so you could all be on your way back to your respective homes. So with that, we'll leave here at 12:45. If you're driving yourself, please make sure you're over there no later than 1 so that we can get going with our tours. With that, yes, Jess. So let Jess know if we're driving ourselves so that they have the right number of transport. With that, Representative Brown Powers moves, we arise. Thank you, folks.
Like, just some common sense stuff. So, a good question would be, where's Jess's chart? How many beds did they say we have to cover with intensive residential service homes? I have 4-bed facilities that I pay $350,000 a year. So, for 12 people, it's $1 million. Aren't they supposed to serve like 100 and some people, 200, 400? I don't even remember. So, they're saying this is going to cost a total of $1 million. That's just basic math.